Evening, everybody, and welcome to the Mental Health Professionals Network interdisciplinary panel discussion via webinar on a collaborative approach to supporting adult survivors of child abuse. This has been the most well-subscribed MHPN webinar so far, and there are over 400 participants actually online and over 1,300 people registered. So we're really pleased with that response, and clearly it's a topic that people are really interested in. So my name's Mary Malaya's. I'm a GP in Cairns in North Queensland, and I work at a headspace. I'll just offer you a few bits and pieces about technical aspects of this evening before I introduce our panellists. I'll introduce the panellists first. So Kathy Kettleman, you have all received some biographical information beforehand. Kathy is a consumer advocate on our panel tonight. Richard Benjamin is a psychiatrist from Tasmania. Now, I should say I believe Kathy is in Sydney.
Sydney, that's right.
Yep. Kathy's from Sydney. Richard is a psychiatrist from Tasmania. Welcome, Richard.
Thank you.
Philip is a psychologist from Sydney.
Hi.
Philip, I don't believe that you and Kathy have ever worked together. Is that correct?
I know of Kathy, but I don't think I've ever met face to face.
Yes.
Not directly.
Yeah. And Joanna is a GP from Brisbane who has a special interest in complex trauma. So it's going to be a really interesting panel discussion tonight. Just some technical information. Because we do have so many participants on, I have read the questions that you submitted at your registration, and you are welcome to type them into the chat box, which I will try to monitor. But please be understanding that we may not be able to answer all the questions everybody has submitted. And post your comments and questions to panellists in the chat box if you want to. If you have technical help problems, please post them in the technical help chat box. If you can't see the chat boxes, it's because you need to put your application onto full screen, and you'll see a little icon in the top right-hand corner to do that. Your feedback is really important to us, and there'll be a short survey which will appear as a pop-up when you exit. So thank you for filling that out. Now, learning objectives for tonight is that we would like people by the end of tonight to be better equipped to raise awareness of the prevalence and the indicators for complex trauma, identify the key principles of intervention in the featured disciplines assessment, treatment and support of people who have experienced complex trauma, and recognise the merits, challenges and opportunities of interdisciplinary collaboration in providing mental health support for people who have experienced complex trauma. This evening we're going to be talking about Judy, who was sent to us in a case study before tonight's webinar. This is a de-identified vignette, and Judy is 61, and you've read the case. So she presented to the emergency department. She's also seen her GP. She saw the ED mental health team, the intake officer, and a psychiatrist. What is going to happen is that each of our panellists will give a short discipline-specific response to the case, and then followed by question and answers both between the panel and between the panel and the audience. So without further ado, I would like to welcome Kathy as our first respondent. So what we'd like the panellists to do is to talk about their first response really, and how they would respond to somebody like Judy. So Kathy, I'd like to hand over to you. Thank you.
Thanks so much, Mary. Well, I thought seeing we're talking about complex trauma, we need to just look at what it is and really differentiate it from the trauma of a single incident, a flood, a fire, physical sexual assault in adulthood, and not to minimise the impacts of those traumas. But when we're talking about childhood abuse or domestic violence, child being impacted by domestic violence, that's often repeated, it's often extreme, and it's interpersonal, so it's perpetrated by the very person charged with the child's care, and obviously potentially has very substantial impacts as a result of that. We're looking at why we need to know about complex trauma. Well, it affects and this is a conservative estimate, 4 to 5 million Australian adults have experienced childhood trauma in its broadest sense. And there's a quote here from Vincent Felitti, who we're going to talk about, refer to a study he's involved with. And what he's expressing here is an absolute shock about the prevalence, but also a shock in that he went to medical school. Why didn't he know about it? Why wasn't he told that it was so prevalent and has such profound impacts? What we know is that people presenting to mental health services in Australia, figures of sexual abuse, physical health issues, more than two-thirds of people presenting to services have experienced those forms of abuse as a child, let alone the other forms of abuse and domestic violence. And people don't just present to mental health services, they present to a whole diversity of other human services. So we referred to the ACE study, Adverse Childhood Experiences study, earlier. This is arguably the most substantial study of its kind. It's been going on for 17 years, 17,000 participants in the US, and looked at 10 different forms of childhood abuse, chronic neglect, other forms of adverse childhood experiences growing up with a parent with a mental illness. Parent is again what we've observed, that these experiences are way more common than is recognised or is acknowledged, and that they have powerful impacts on both physical, mental health and psychosocial functioning. What's also become very apparent from this study is that, when children are impacted by abuse, neglect, other adverse experiences, they cope as best they can. They use different coping mechanisms because they need to survive. But what happens is that these coping mechanisms, which are originally protective in terms of allowing them to survive, become risk factors for physical, mental health issues in later life. And that's very important to acknowledge the coping mechanisms, the resilience that people have in surviving, but yet to look at what the effects of those are and work with them. When trauma is unresolved, when complex trauma has not been addressed, when it's not been acknowledged, not been identified, it can potentially affect a person right through the life cycle, the child, the adolescent, the adult. And also when those people become parents, it definitely can affect the children. And certainly we've seen in Judy's case that what she's presenting with is a transgenerational story of complex trauma. And we've seen, her daughter's affected, her granddaughter. We know from neuroscience now that even though damaging experiences can cause negative impacts on brain growth development, we also know that positive experiences can aid recovery, and that recovery is possible. People can recover. And when adults have worked through their trauma, we know that their children will do a lot better. So it's very, very important that our services reflect that the research base is now very firm, but we need to see that research put into practice. And hence we talk about trauma-informed care. So care that is informed by the awareness of the possibility of trauma and the effects of trauma on the developing brain, the effects of traumatic stress and how people cope. And as I said, there's a very wide research base. We know that we can map the effects on the brain, but we can also see that with positive experiences, when people have been abused, they've been abused in an interpersonal experience, they've had a negative experience, they lack trust, there's a power imbalance. So it's very, very important that any relationship, but obviously relationships in services, in organisations, and with practitioners, reverse that script and are positive, and that's the basis of trauma-informed principles. So with trauma-informed practice, we need to acknowledge that, so many problems and so many disorders which carry mental health labels are trauma-related. We need to understand the multiple potential impacts of trauma, need to be sensitive to the context of the treatment and the service and how it's offered, so that service is very aware of the potential for people to be re-traumatized, and understands also those coping mechanisms that people have used to get through, to not judge them, but work with them, understand them. Major question we need to start to ask, and I'm a medical practitioner by training, and I was trained in the medical model, symptoms, signs, diagnosis. It's looking for pathology. It's looking at what is wrong with someone. But what we need to do is ask the question, and ask it repeatedly with understanding what happened to the person, what happened to the person right through their lives, because trauma is often repeated. How have they coped? And we need to admire their resilience for having coped and having survived. The skills they've used, we need to identify the skills, empower people to build on those skills. Core principles of trauma-informed practice: safety, and safety that's physical, psychological safety, absolutely crucial. Developing trust. When someone's been betrayed at such a primary level, trust is absolutely critical. Having a choice in what happens to them, really collaborating in their care, changing the power differential of being the practitioner who knows best, and working with someone as to what they want in their own care, what recovery means for them, empowering them. Because we know that, working positively in a relational way aids neural integration, and neural integration absolutely imperative for well-being and for recovery. So, this makes total sense, but we also need to be aware that adult survivors of childhood trauma have had very little experience of these core principles. Many people have never, ever felt safe, and it can take an inordinate period of time for someone to learn to trust and to actually know that they not only do they have the capacity to make a choice, but what that choice might be. But these principles are absolutely foundational and need to be built into all interactions. So when we're looking at Judy and what Judy needs, as we said, it's a transgenerational situation of complex trauma where the impacts are compounded personally, intergenerationally, over time. We need to look at the impacts of traumatic stress on her family, understand how she's coped and how she's worked to help herself in the best way she can. We need to help her feel safe. We need to build that trust and engage in positive interactions. It doesn't matter how trivial the interaction, but a positive one, so she can rebuild that sense of hope towards recovery, work with her strengths, and find a way forward. Thank you.
Thank you very much, Kathy. So in our scenario with Judy, and the next kind of person that is parallel to our panel tonight that she met really was the psychiatrist. So I'd like to welcome Richard to respond to Judy as he would have had he met her. Thank you very much, Richard.
Thank you, Mary. Thank you, Kathy, for starting, and thank you, MHPN, for inviting me to be on this panel. I think in the context of what we're talking about tonight, it's really important for me to give a little bit of background. I'm a psychiatrist. I am... Ooh, so something come up on the screen. Can you hear me?
Yeah, we just can't see your webcam, Richard, so I think you need to hit allow. For some reason, we've lost your picture.
Whereabouts?
If you can't see it, just keep talking because we can hear you. But if you've got an instruction there.
Nothing here.
Okay, what I might do is actually ask Philip to speak now, if you don't mind. Oh no, here we go, there you go. Go ahead, we can see you.
Thank you. Yes, I'm just thinking that in the context of what we're talking about, it's really important for me to give a little introduction about myself, and that is that I'm not only trained in psychiatry, but I'm also trained in the conversational model of psychotherapy, which is a model of psychotherapy based on the long-term consequences of child abuse and adulthood. It's important also to say I work solely in a public sector setting in a community mental health team, And about half of the patients I see have what people would traditionally see as major mental illness. These are the psychotic illnesses. But I think the predominant component of the other half of the patients that I see have problems subsequent to childhood abuse, that is complex trauma. And now I can't move the slide forward. It's really important to note from the very beginning that early and profound trauma can have very significant biological effects. This slide shows the brains of 2 3-year-old children. The brain on the right is significantly biologically impaired and is at the 3rd percentile after 3 years of severe sensory emotional neglect. Now, I put this slide up about childhood abuse just to remind me to say that we're talking about all sorts of different kinds of childhood abuse. Kathy has already referred to these in the ACE study. But from my point of view, it's important to recognise that all abuse is emotional in one way or another, and infants and children need to be valued, and all attacks upon value are destructive. Kathy's also spoken about the long-term effects of trauma and that there are many different symptoms that can be subsequent to childhood trauma in adulthood. I'm not going to go through them all here. There's a long list, but they involve a lot of psychiatric conditions, a lot of medical conditions that's very important and under-recognised, and a lot of social conditions. And the problem is that there are many, many symptoms that can follow childhood abuse, and they can get a bit lost. Now, the reason that they can get a bit lost is due to a phenomenon, I think, that's been named up by 2 authors called Lincoln and Arden as the Pax Medica. This is a phenomenon in psychiatry, and it refers to the combined effect of the DSM classification manual, the effect of the drug companies and the use of medication, and the rise of the evidence-based therapies combined together. And these authors see this as a paradigm that's inappropriately founded on theories of chemical imbalance in the brain, with an inappropriate emphasis on symptom-based diagnoses and on specialised treatments and techniques. And they say that these together have medicalised psychology and psychiatry in a way that it's become so pervasive it's almost invisible, like the air we breathe. Now, the DSM in particular causes particular problems, and that's because it diagnoses almost exclusively by symptom clusters. It was set up as a research tool, and it's become understood to be something that it isn't. And that is that it doesn't describe diseases. In the rest of medicine, we use the ICD, and we look at organ-based dysfunction. That doesn't happen in the DSM. And the DSM leads to questions being asked about symptoms. Generation multiple diagnoses. It's not unusual to see 4 or 5 different diagnoses in patients that have suffered with complex trauma.
Can I just interrupt for a second? Richard, it's just a little hard to hear you. I wonder if you could move the microphone closer to your mouth. And also for our other panellists, just to remind you that although we can't see you, we can still hear you. So if you're moving papers and things, everyone can hear. Thank you, Richard. Sorry to interrupt you again.
Any better?
Great.
Better?
Yep.
So what the DSM tends to do is it tends to move the clinician away from both the current psychosocial context and the personal developmental history and away from the abuse or trauma. Now, I know Joanne is going to talk about this a little bit more later on, so I'm not going to go into it in any great depth. But the diagnosis of complex PTSD pulls together all these symptoms so that we can understand that patients are suffering as a result of trauma and don't have lots of different diagnostic problems. Now, I think this is a crucially important concept, but it's important to look at this at an even greater depth. I'm going to talk a little bit now about normal and abnormal brain development. And it seems fairly reasonable to suggest that the history of mental illness has been largely one of 2 different paradigms over the last 100 years. There are those who think the illness is predominantly secondary to brain disease, and those who think it's predominantly secondary to cognitive or emotional causes. But there's a 3rd paradigm of mental health, and it's very important. And it was the first seminal text about this was written in 1994 by Alan Shaw. Now, he says that our brains are socially constructed, and Alan Shaw says that the interplay of experience and development are especially important in the early years of life when neural networks are particularly malleable or plastic. He says that in modulating the infant's expression, the caregiver directly influences the infant or the child's later capacity for self-regulation. This is really important, that all attachment experiences are primarily emotional, and these experiences become embedded in unconscious, bodily-based memory networks as unconscious relational memories. That is, we are created in the context of other people. This is Mary Cassatt's famous 19th century painting of mother and child, and this painting demonstrates the importance of the dyad, or the relationship, that we're now starting to focus on more and more. Now I'm going to talk a little bit about the school of psychotherapy that I've trained in, and Professor Russell Mears, in concert with Robert Hobson, who was in England, developed this theory, and it's pretty important to recognise that Professor Mears is Australia's foremost expert on borderline personality disorder, and over that 30-year period he has developed an evidence-based and effective treatment for borderline personality disorder. Professor Mears says that the sense of well-being is directly related to feeling valued, and that this sense of value is lost in the majority of those who are seeking therapy. And the damage occurs when caregivers have consistently failed to respond to developmental needs, or when trauma has been actively inflicted. Now, it works on the understanding that the childhood trauma is lodged deeply in the unconscious, and this manifests throughout life in relationships with others. So the treatment focuses on the emotions that come up in the therapy.
Richard, people are really enjoying what you're saying, and it's a bit fast because we pressured you to do it quickly. So would you be able to slow it down, because the audience are really valuing the depth that you're going into? Thank you.
I realise that we're already running out of time, so
don't worry. Let me look after it. They're enjoying what you're saying, so just take your time.
Thank you, Mary. The treatment in the conversational model, which I'll leap straight into, which really need a lot of introduction, but I'll leap straight into the treatment. The treatment mirrors to an extent the mother's responses to the baby in the proto-conversation evidence in the painting by Mary Cassatt. And there are three techniques that are critical in this technique involved in the conversational model. And the first part of this is joining. And joining refers to an attempt to get into the same space as the patient. This is really, really important. You have to have time and space. And in public mental health facilities, this often doesn't occur. The other thing that's really important is that the therapist has to abandon their own agenda, and they have to follow the patient, and they have to truly and deeply listen to the patient. The second part is representation. And representation, simply but in a complex way, it requires the therapist to very quietly, very gently and very speculatively try to put into words and expressions, like the mum in the proto-conversation, what the therapist thinks the patient is feeling, and most importantly, to see how the patient responds when you make a representation. The final part, amplification, I have not seen in any other form of therapy as a particular technique. And this refers to an attempt by the therapist to follow the patient's emotions in very minute detail and magnify any general positive feelings. While we're talking about amplification and feelings, the therapist must also sit with and bear witness to the patient's pain. Now, all this comes together in Judy. In my experience, I've seen many, many patients like Judy, and they are very, very often, particularly in the public sector, seen cross-sectionally with a focus on risk management, symptom clustering for both diagnosis and treatment. Very frequently, early history is not taken, or it's not taken comprehensively, and the relationship of the early history of the symptoms isn't made. In the mental state, similar level of attention is given to factors that are often associated with childhood, or the signs are misconstrued, and there are quite helpful signs in the mental state of early childhood trauma. And the end result is that the whole situation might be biologised, and Kathy's already mentioned that this situation is one involving 4 generations of trauma. From my point of view, the most important thing to do is to see that trauma is a central part of this. I think you would do a disservice to the patient to see this simply as PTSD, although the PTSD symptoms are important. But for the patient, I think the intra and the interpersonal problems are critical. The self-loathing, the sensitivity to criticism, the inability to cope and tolerate others, all of these things that were missed early on will have made Judy's life most difficult. Just to finish up with the last slide, using the conversational model, which has principles similar to a number of other psychodynamic psychotherapies, I think what's most important are very genuine and very human responses. Judy needs someone to listen to her, and she needs someone to have the time and space to do this. I can't repeat that enough. She needs someone to try and make sense of this with her, and this can happen over moments or over months or over years. She needs someone to sit with and bear witness to a negative emotions. Her mother couldn't do this. That's very important. She also needs someone to be acutely aware of her sensitivity to and her inability to tolerate others, and not buy into these problems on an unconscious level like almost everybody else in her environment will. If you can do that, you can provide a different response and a different channel for future growth. When the patient is given a real chance to tell their story, Judy is listened to very deeply. She can begin to heal. Thank you.
Thank you, Richard. I'm going to be slightly out of line. There's just a question from the audience that I think is appropriate to raise now, which is just, could you give us an example of amplification in Judy's case? Is that possible?
Can I give you an example outside of Judy's case, because it will be simpler and it will be more straightforward, and it will deliver the message, and it's straight from one of Professor Mears' books. The patient's a woman who is very fragile. She's been in therapy for some time, and she's with a therapist who's normally very, very good. But the therapist misses something that Judy says at the beginning of the session, that the patient says at the beginning of the session. The patient is agoraphobic, and the patient says very early on in the session, I went out for afternoon tea on Saturday, and the therapist doesn't say anything. Now, the opportunity to grasp what has been done at that point is fabulous. When patients are very traumatised, you can often overshoot, and they will withdraw if you praise them. But if you can recognise that that's an important step and gently encourage by leaning forward, by making positive emotional expressions, then that can start the process of healing and growth, as well as the integration of trauma. They're both very important. Does that help?
That's helpful. Thank you for that example. It's really clear. Philip, thank you for continuing with the psychologist's perspective.
Oh, thank you for the opportunity. Yeah, Judy, first thing from a psychological perspective, just hang on while I activate my camera.
I'll move your slide for you while you're doing that.
Okay, that's okay.
I'm going to make sure that
Judy has all the, if you like, the contextual needs and wants for her daily living somewhat covered in the initial crisis assessment. I'll be checking for her safety, her social welfare, her accommodation, her financial means, providing direct support to financial counsellors or accommodation opportunities in my mind, and certainly give to Judy as soon as she's able to take them on board. So I'm gathering that information and I'm storing it up ready to offer it to her in case she can make use of it. I'm going to check her relationships, who's supportive, who knows about her malaise, who's not supportive of her, just to get an understanding of the supports and the relational networks that she has. I will be checking her medical history, just in terms of, does she have a GP? Does she consult with her GP regularly? Does her GP know where she's currently at, how she currently is? If she has a psychiatrist or she's been to hospital recently, what medications she may be taking, just to get an understanding of who's who, and to get her consent, if necessary, to liaise with those people. I'm also going to check her ability to work and study and to focus on day-to-day living things, plus to check if there's any legal matters, any court that's pending. Basically, I'm checking for threats. What is a threat to this lady right now? Because threats will regress her level of functioning psychologically. So I want to find out what the threats are and see if I can provide information or support immediately that will somehow give reassurance that we can address those threats. We can help her. She is not alone. We can provide what resources we can get for her so that her nervous system basically doesn't feel so threatened, so she can be more present to take on a depth of further psychological therapy. So it's important for me that I get to her, to that, if you like, that parasympathetic level of functioning, that calm level of functioning. I'll follow up with her, any referrals I make or information to check on her progress as needed. Once I've covered that basic assessment and triage, which I do, as quickly as possible, I'm going to move into having more of an assessment on how her mind is, the function of her mind. And what I do here is I utilize Gregory Batesons' proposition of the mind, that the mind is made up of many parts, organized into a whole. That these parts within us, the different parts of the mind, which the mind is dynamic, the mind is plural, if you like, the mind is relational. So I want to find out the different parts that she's expressing. Now, I know that Judy expressed that she's feeling overwhelmed, feeling trapped, feeling not good enough. So I'm listening for that and hearing that there are parts within her that feel overwhelmed. They may be younger parts of her, not her adult self, not her grown-up self, but younger parts who are totally at their wits' end, which I would absolutely appreciate as being, true. If it's a younger part, it shouldn't be doing this adult stuff. It should be resting or playing. I'll be looking for just basically her low mood, her lack of interest, the low meaning that she has in life, and trying to see the different parts of her that are giving rise to those various emotions. Now, the reason I talk about parts is because when people are traumatized, the mind doesn't work as a functional whole, as Bateson's given us. The parts communicate is his second proposition. Traumatized people, there's rules in the mind, and those rules are don't trust, don't feel, don't communicate, pretend, make up stories, lots of good stories, throw people off your track, don't be honest. And it's not that people have poor morals, it's just that they're traumatized and they need to cope by not being fully consciously aware. Again, consciousness, if you like, is too painful. So consciousness here is fragmented and the parts become not part of it. In a family, open sharing communication, it becomes one part just goes off and drinks. The other part doesn't want to drink, but it doesn't get a say in things. Another part smokes cigarettes and so on and so on. Different parts do different things. One part's a caregiving part, one part's a runaway part, so on and so on and so on. So I'm looking at Bateson's model. I'm appreciating many different parts to Judy's mind. These parts may not be communicating. Going down that list for Bateson, there's also, if we get to the bottom of that list, there's a hierarchy of structure in the mind. Now, Richard said that whenever there's abuse, there's emotional aspects to that. There's painful aspects to that. I will also say that whenever there's abuse, there's the absence of a self-state. Now, what I mean by self-state is in the adult that's abusing the child, there's the absence of consciousness in its most broader, if you like, kind, compassionate, welfare-oriented, sensing, sensitive state. That consciousness is not there. So whenever a child is abused, there's an abandonment of the self by the abusing adult. Now the child will be looking for this, be looking, is mum, is dad, are they present or are they dissociated right now? Are they disconnected? Is there self there? And the child will be doing everything it can to try and placate mum and dad and soothe mum and dad and make things work to get the self state as much there as possible. Now this self ought be at the hierarchy, ought be in executive control. Consciousness on that broad, kind, welfare-oriented sense of mindful self ought be in executive control. But in trauma, that gets marginalized. Consciousness gets kicked out the door. So you just have piecemeal parts of the mind doing their individual things. And that's what I encounter with Judy. Different parts of her having different needs, no sense of being able to regulate or talk to these parts of self. She's fully overwhelmed. She's at her wit's end. So in terms of treatment, I'm bringing in consciousness, mindfulness, helping Judy notice. I'm reflecting what I notice. I'm attending to her implicit state, so her autonomic state, her arousal state, not her story so much, but how she is in the moment. I'm working with the nervous system to calm her down, and to that end, I draw on Stephen Porges' polyvagal theory. I'm also working with the hierarchy of the mind, and to that end, I'm looking at Minuchin's ideal model of mammalian structure, where it should be the most mature mammals, if you like, looking after the younger ones, or the most mature self looking after the hurt self. And I'm going to support the defenses she has, just as because they're self-protective in complex trauma clients. So I'm welcoming her, I'm helping her be mindful, and I'm essentially nourishing interventions. I'm not picking on pathology. I'm offering that she seems to be very overwhelmed, and it might be good to rest for a moment. So how about we do an exercise around that? How good this chair that you've been sitting in, you've been telling me all the problems of the world, and it seems like you're really stressed. How about you come and sit over in this other chair? This is, you need to use your imagination here, but we'll call this the stress-free chair. And I get Judy's permission to come over and sit in the stress-free chair. Now, a few things I'm doing in that intervention, I'm encouraging her to have an active flight response. I want her to run away from stress. That's a natural response. I want her to get away, and I want her to have success in that. So if she's able to get into the stress-free state and her nervous system's able to calm down a bit, I'm going to help her be more mindful. I'm going to process that experience and really hang out with what feels good to her about feeling a little bit less stressed, or a lot less stressed. Secondly, I might attend, so that's helping her physiological, her sensory motor state. The other aspects, I want to help her mind. So I want to see what parts of the mind are present. So I'll be being mindful myself, and I'll be inferring that there seems to me that there's a part of you that really works hard. You know, it looks after others so much, but is really worn out and sick and tired, even suicidal. So I'm reflecting parts of her story and what she's saying. And I'm checking with her, is that right? And then I'm going to ask her, do you notice, how are these parts of you now as we talk? So I'm wanting her to turn inwards and notice how her mind is and what parts of her mind are present with me now. So I'm inviting that mindful or self state to come back into its hierarchical position in her nervous system, in her mind. Then I'm going to be offering some potentially nourishing interventions. Again, potentially nourishing because it's an experiment. I'm just going to see if this works or not. I don't know if it'll work, so I'm going to see if it works. So I ask her, would it be okay to explore these parts of your mind? You know, maybe do it one at a time. So I'm thinking, let's not do everything all at once. Let's do one at a time. And I'm going to make friends with the different parts of her. So one of the things I might do is, I hear that you're exhausted. I wonder if we can just hang out with those parts of you. Maybe the way we can do that, here, just have a cushion and put your head down on the cushion. Just have a rest for a minute. And notice, see if that feels nice, see if that's good. So I'm helping that part of her, those experiences that are coming through, to have a break and have a rest. And then I'm going to look at the other part of her that needs to soldier on and look after her kids and, keep productive and so on. But one thing at a time. Now, the bias is attend to the developmental structures. Babies, when they're born, what do they need to do? Sleep, rest, be nourished. So I'm going to offer interventions that are geared towards resting, taking it easy, exploring those parts of the mind first, see if we can stretch out whatever feels good about that, and then moving on and looking at things that come naturally later in development, action-oriented stuff, sociable stuff. Hopefully we'll get to some positive outcome. Let me see if there's anything else. Mostly that's what I'm going to do, and help her hang out and be mindful and be rested, and see from that change of state if she's able to then go out into the world and function a little bit better until next time I see her. And that's all from me.
Thanks very much, Philip.
Pleasure.
I'm just delighted with the complexity of the information that everybody's been providing, and I think that we shouldn't hurry, because I think Joanna has a whole lot of additional stuff that's just so helpful. I've learned a lot myself already, and this is an area that I work in every day, so I'm just delighted. And Philip, that was really, really interesting. Lots of practical things we can do straight away. Johanna, being a GP, you actually see lots and lots of people in your work, and I know that you've developed a special interest in trauma. So I'd like to hear how you would respond to someone like Judy. Thanks.
Hello, everybody. I am speaking as a GP, actually a GP who saw many patients like Judy, who didn't have as nice a psychiatrist as Richard and as listening psychiatrist as him, and ended up back with me having had re-traumatizing in hospital settings and in the different places they were sent. And so as a result of that, my practice has changed, and I've set up a multidisciplinary clinic in Brisbane, hoping to provide some of what I saw was missing in the setting I was working before.
Johanna, could you just move the microphone a little closer to your mouth? And Philip, could you just make sure that yours is muted? Thank you.
Okay.
So I just sort of, and my initial response to Judy's story was real sadness at the late diagnosis, and some hope that even now she can experience understanding, safe connection, growth and repair in her relationships, and also hope for her grandchild, because the trauma that's been inside this family is no longer unacknowledged, and there is potential for safe treatment for her, which there wasn't before the trauma was identified. I graduated at a time when a person with such emotional dysregulation would have been considered a poor prognosis and dismissed as someone to be managed. But there's been so much research in many fields, including the recovery literature written by mental health sufferers who've recovered, that brings hope. Other key research fields that have influenced my practice are the attachment, trauma, dissociation, grief, sensory motor, neurobiological and interpersonal fields. That, really this is a story of humanity. The other place that I've received hope is in seeing patients who had been written off by the system recover and no longer need mental health professionals in their life. And also in the interactions with the mental health professionals that I am meeting more and more of, who continue to hold and provide hope for those in their care. And I think there's lots of you listening here tonight. One word that used to bewilder me that now gives me challenge and hope is complexity. It's an experience that I found frightening in the diagnostic and treatment process in my early years as a GP. But now I see that if we're willing to sit with complexity and see it, it offers multiple ways to help each person. It's uncomfortable to not be able to diagnose and narrow down symptoms and signs to something we know how to handle. But sitting with complexity requires the best of our scientific detective skills and willingness to learn. And it requires that we acknowledge that we're not experts. Instead, we're learners too. I just thought I'd start with my noticing of Judy's complexity. She has complicated relationships affected by mistrust and alienation, and has identified difficulties with intimacy and touch, and feelings of isolation and a lack of protection from her family. She's got complicated emotions and distorted ways of handling them, extremes of sadness and anger, sudden changes in emotions that she finds difficult to manage, deliberate self-harm, and I would include here suicidality, that I find a lot in my trauma patients as the experience of a very small child just not wanting to have the problem that they're coping with, wanting to disappear, a bit like the floor opening up. And so a lot of suicidality I would see in the same way that Philip sees it in parts, and that unity inside can help a lot with that. Complicated personal history, ambivalence with relationship to her mum, some very clear betrayal by her mum and yet loyalty to her mum, not being heard, being beaten, not being seen by her father. And here I'd really like to emphasize the issue of neglect. It's a really hidden form of abuse that's in our culture, and I see quite a lot of children or professionals who've experienced emotional neglect as their parents are preoccupied with their work. Complicated connections to her memories, flashbacks, nightmares, feeling trapped, amnesic episodes, and confusion about what she remembers. And, this is an area which has sparked controversy in some parts of the world about how people remember. There's so much research, I only know the tip of the iceberg with it. But what I do makes me very respectful of how memories can get hidden from the self in the way that Philip has mentioned, and we talk about not seeing what we don't want to see or what we can't know or can't bear knowing. She has a complicated relationship to herself, feeling not good enough, suicidal, sensitive, helpless. And that's only what she's mentioned in this vignette is only a fraction of what she feels. And those feelings we often will feel ourselves when they walk in the room, and we have to be very aware of not being co-opted into the story that they've repeatedly received from other people. Complicated relationships to health caregivers, and they are not seen or noticed in amongst our system. We have a system that is also not noticing. There's many disconnected assessments and, not noticing her current triggers and how they're linked to her past. I have just put as my next slide, if I can get it. Sorry, Mary.
I'll do it. There you go.
I've got it. Oops.
Sorry. Yep.
Okay. This is taken from some work by Christine Courtois, and it's really just a nice simplified list of the things I've mentioned about Judy, that her affect regulation, and I really would concur with what Richard said, that what we're dealing with is a disorder of how people present themselves, and many of the things we would see as symptoms and even diagnose as comorbidities with substance abuse disorders or other names we give them are actually forms of tension reduction behaviours that trying to help themselves manage extreme disorders of affect, and that's related to not receiving soothing as children and knowing how to receive soothing. There's it alters attention and consciousness, it alters self-perception, it alters perception of the perpetrator, and this can be a very complicated area in treatment. It alters relationships with others, connection with their body. And, in my role in general practice, I look back, having grown in my understanding, and see so many of the repeated visits to the doctor or chronic pain situations where what I've learned in the care of the complex traumatized people could have helped. And it alters systems of meaning with, despair and hopelessness, feeling punished, so on. But there's also a beautiful literature in post-traumatic growth and the areas of sense of self, connection to others, and meaning have been shown to grow as a result of trauma as well. And, I think that's the deep hope of this work. I mention here the concepts of integration, coherence, and being held as sort of central to this work. There's been a growing realization in my practice, influenced by Daniel Siegel's research into adult survivors of child abuse, explaining the concept of a coherent autobiography, having far-reaching effects on an adult's ability to parent after they've experienced child abuse. And he's further expanded these ideas to consider neurobiological processes connecting left and right brain, cortex and limbic system, mind and body, and self and other. And I just want to mention that as an overriding concept in this discussion. I would see coherence as really important in how I would approach Judy. I need to be coherent in my own self, notice my own pain, my own reactions, be aware of the positive and the negative inside myself, be aware of my own expertise and my own lack of expertise. And in coherence in seeing her whole person, even though she may be only seeing herself in parts, I am seeing her as a whole, and one of my jobs is to continue to hold that in my mind as I see her. I am aware of her capabilities as well as her pain. I'm aware of her child who feels frightened and unable to cope with life, as well as the one who brought her in and made the appointment. And those are that's part of my task in providing coherence and holding. The other thing is just being aware of all the different aspects of her social world, her body, her mind, her self and spirit, and then in what I can see and what I know is hidden, and be aware of that hiddenness. And I would see that we need to provide coherence in the system, and that's partly why what I'd be hoping to notice in our conversation tonight, that it's more than me, it's more there's more research and clinical ways of managing than I know. It's more than symptoms, it's more than medication, and there are other ways of seeing and responding and other ways of caring that all deserve respect. Trauma and neglect divide. I talk about with my patients how it causes civil war inside the self. There's horrible relationships internally that revolve around betrayal and alienation and punishment, and it divides relationships, the patient's relationships with the other people in their life, but also with the community around them, and with the mental health system, and it divides our community as well. And this discussion is difficult. It's difficult within a context of the system that we are part of, as Richard's alluded to at the beginning, what I would call descriptive psychiatry, that describes symptoms but doesn't notice the person. And I see it requires input and energy and an active decision amongst us as mental health professionals to work towards unity and team and mutual respect in the presence of pain and trauma. I'm just mentioning dissociation here. I'm not sure how many of the listeners will know quite a lot about this, but even the concept divides. I still go to mental health meetings when I mention this word. I'm dismissed. And yet there's a large body of research. There's an International Society for the Study of Trauma and Dissociation, and there's a really great course there, which I've done. So if anyone's wanting to know more in that area, it's possible to know more. And, there's some beautiful, clear descriptions of it, and now research and research tools to look at it. And there's still some not understanding of the neurobiology of it. Some would see it in different ways of how it comes to be or what it's doing in our brains. But the main point is that it's a division of consciousness or personality, and it involves a parallel owning and disowning of experience, an experience of not me. And I don't know how many patients you have seen that are sort of coming in one way, you expect them one way and they turn up in another. And they have parts of them that they don't know. They speak stories or ways of being that they then don't seem to agree with, and it's quite bewildering to be with them. But it's also a spectrum. I would see it from the position we're in the discussion. We don't know how to get from how we got from A to B, what's called highway hypnosis, all the way through to dissociative identity disorder, where the person's really amnesic for the other parts of themselves. And in the middle, there are those of us who have a part of us we disown or do not want to know or acknowledge, we're ashamed of or frightened of, and an experience of emotion in that part that we try to avoid. And in childhood, that's really adaptive. When someone's trapped and cannot get away, or they're in a relational double bind, the not knowing or not connecting to that part is a good decision, because it's a liability to be in the presence of such overwhelming emotion when you're trying to live a normal life, trying to do your maths sums in grade 4 or make a friend at school. And so it's really adaptive in that setting. But it does mean that there are some parts of the person that they are unaware of, and that has implications for how we treat them as adults. And I think of it like I need to have therapeutic rapport with multiple parts of a person. I need to engage the part of them that's coping and build their confidence to know, to grow in the awareness of what has happened to them. and also engage with frightened and angry and scared and shameful parts of them as well in the conversation. I have looked into this area, and really I feel that transdisciplinarity, being aware of the multiple ways of seeing amongst the paradigms of mental health, is one way for us to address the problems that these people face in a system that can split around them. And I think of it as all the different ways that we hold. I think that generalism, obviously I come from a general practice background and I'm a bit biased towards generalism, but I think it's a little bit of an antidote to reductionism, and it can help protect us from our not seeing of the person, not seeing of things we don't know about or don't want to know about. I think there needs to be a willingness to tolerate not being the expert, and the uncertainty that all the hidden and unknown things bring with each of these people. I think this is a real cultural shift. In the clinic that I work in, we really value highly respecting one another's opinions and ways of seeing and personhood. And I think this is something we need to grow in how we communicate amongst ourselves as mental health, and metaphor and beauty to help in the care of these people. And I need to be aware that I cannot see and hear all that needs to be seen and heard. For me, that's why the importance of working in a team and allowing them to be seen by others, just as all of us are. We don't have one person in the universe who sees us and holds everything about us. We have multiple people in our lives, and I would see that could happen in the mental health field as well. I hope for a system that works coherently. I've got some quotes that I love. One is from Judith Herman, who was a real founder of noticing of of trauma in our community, and she says these two quotes are on our wall in our kitchen at work. Just as no survivor can recover alone, no therapist can work with trauma alone. And another from Brene Brown, who did a beautiful TED talk on shame, said vulnerability is our most accurate measure of courage. And I think of that in my own vulnerability, in being the non-expert, but also really seeing the vulnerability of those who have come as courageous. I wanted to mention the centrality of safety. The main body of work on trauma-specific care is helping the person feel safe enough to grieve what's happened to them. And I see that safety as broad-ranging. Philip alluded to this in his initial assessment, that it's in their social setting that includes finances and housing and work, in their relationships, in how they handle boundaries, in how many abusive relationships and ambivalent ones they might need to clarify. In their body, sleep, appetite, exercise, chronic pain and somatic memories need to be acknowledged and cared for. In their mind, what they're thinking about and how fast they're thinking, and in their emotions, understanding and managing the hypo and hyper arousal that they can experience when they have memories. That Philip mentioned a little bit of that in his polyvagal theory. In their sense of self-esteem and in their spirit, and how they make meaning out of a world that includes pain and trauma. I really wanted to emphasize that we are not being archaeologists when we care for traumatized patients. We're not trying to dig up their history. And in some ways, some of the structured ways we're encouraged to take mental health histories is really quite dangerous or destructive for this group of patients, because they fear what they don't know, they fear what they do know, and we don't want to activate too much of what has happened to them in our initial meeting with them. And so Courtois has a beautiful quote that says, emotional content associated with traumatization can be overwhelming, and the therapist needs to give individuals safety and welfare precedence over the story. I would really encourage that in how people are thinking about this area. So I just wanted to end with my hopes for Judy. My hopes for her is that she's listened to with safe connection and context, that she grows in hope and power, that she's taught to be less phobic of her emotions and to be confident to soothe her levels of arousal using sensory motor awareness and creativity, that she's taught to understand the triggers that she experiences, that she can begin to see her relational patterns. At her age, I don't know how much to hope for in what can change in her relationships, but just to start to be aware of relational patterns, that she could notice all of herself and learn to be kind and caring, including what I call intrapsychic unity, that the parts are noticed and listened to and cared for, that she can engage other help, and that includes simple things like exercise, her GP to make sure her teeth are okay, and her she's had her latest skin check and all the practical things, and help in her parenting role and grandparent support. There's an organisation that can help her grandchild, children of parents with a mental illness, and family therapy in an ideal world. I still don't really hope that can happen now because I don't think it's possible. And be helped by a team that collaborates, focused around her body, mindfulness, art therapy, mental health nurse, family therapy, psychiatrist, psychologist, and GP. I think we can.
No. The presentations from everyone have just been so full. What I'm going to do is override your right to ask each other questions, because I already knew what they were going to be. And I want to integrate those with some of the questions from the audience. So first of all, I know that Johanna had a question for Kathy, which I think ties in with some of the things from the audience. So Kathy, I wonder if you could answer for us what kind of things made it possible for you to access the help that you needed? What were the kind of practical things that helpers, clinicians, doctors, therapists did to make it possible for you?
Look, I was very lucky. Firstly, I had the capacity to afford ongoing care, and I think sadly in our system at the moment not many people have that capacity. I found a therapist who was able to be with me, to sit with me, to bear witness, to hear the unspeakable, support me unconditionally, be empathic, and build trust, which took for me a very, very long time. It took a long time for me to feel safe, and it took a long time for me to know that someone could actually keep me in mind, because that was an experience I'd never had as a child. So for me it was a very gradual process of changing the script in my mind, that I had to be fiercely independent, and that vulnerability was not to be shunned. As Joanna said, vulnerability actually is courage, and to understand that, as human beings, we can all be vulnerable, and that's what's really important for practitioners, to know that we're all human beings, we all have a vulnerability, and to be there for one another with that human sense of how to relate and how to understand what really isn't frailty, but is a normal response to repetitive trauma. So I was very lucky. I found someone who could be there for me in that way over a long period of time.
And Cassie, I'd like to ask you a question from the audience. How is it that, I guess you don't need to speak from your own experience, but in what ways can helpers, therapists, doctors, whoever, protect the patient from re-traumatising by retelling? There's been a bit of anxiety from the audience that insisting people retell their story can actually be re-traumatising for them. So how can we do that in a protective, safe way?
Look, I don't think the process should be about anyone prodding anyone to tell a story. What I believe is that certainly the patient or the client needs to lead the process. And as what has often been said to me is that the slower you go, the faster you get there. So that the patient, the client leads the process, and it's not about digging, prodding to tell a story. But if someone, wants to do so, it's working with what is brought up and sitting with that and exploring what it means and how one's coped with that trauma and developing a narrative for one's life, trying to put those fragments back together, those fragments of the mind, and make sense of oneself, form that sense of self that really didn't have an opportunity to form as a child because that process was disrupted.
Thank you, Kathy. I had a question really from the audience to Philip, but I guess it's, anyone can answer it, but I'll direct it to Philip. There has been a great deal of anxiety about the fact that publicly funded patients often can't get support through local state mental health services, partly because of the distinction between severe mental illness and high prevalence disorders, and trauma is often not recognised or falls between the cracks. So often people are able to access something through Better Access, which was reduced to 10 sessions. So Philip, can you comment on that? Is there something useful that can be done in 10 sessions? What else can we do? Those kind of issues.
I think there is a lot that we can do in 10 sessions, but you have to be clear on making it fast or making it work for yourself and the client. One thing, you can't rush the client, but you can speed up the therapy by, in my argument, by paying more attention to the implicit state that your client presents in. In other words, their non-verbals. So I had a client who just did 12 months with the rape crisis service, and she came to me and said, Philip, I've been going to see the rape crisis service for a whole period of time. She said in the beginning that was fine, so on and so on. I said, well, are you okay to come and speak to a male about, this rape that you've had? And she said, yes, that's okay. Now, when she came to see me, her story again was about the rape, but her non-verbals was about being terrified right here, right now. And I said to her, it can be really nerve-wracking to meet someone new for the first time. And so we attended to her implicit state immediately. And what do you know, we got through that session very well. I think we only did 2 other sessions because actually she didn't want to talk about her trauma. What she wanted to really talk about was being normal, having fun, going out, partying, having a good time. So that's what we got back to. We got her back to her normal sense of self. And so the session actually didn't have to go the full 10 Medicare. It was over, I think, within 3 or 4 sessions with that particular client. So it is possible, but you have to know that really if you attend to the implicit, you're on the superhighway of getting to matters. If you're listening to all the stories, that can be done, but can be a slower way.
Thanks, Philip. I guess the other thing is we don't know that particular client, but I think sometimes a discrete trauma, someone can recover quite quickly and go back to things that they had already developed. And as we talked about it...
I can add one other piece. I asked this person, what did your mum and dad say when you told them about the rape? And this person said, I didn't tell them.
Right.
They've never been supportive. So it opened up a complex trauma history of not ever being able to feel safe, feel comfortable to talk. And all I had to do was acknowledge how sorry I was to hear that, and that was enough. I didn't have to go and explore the history any further, just acknowledge that I was sorry to hear that was the case. And that was satisfying for my client. She felt heard, acknowledged, and we moved on.
That's fantastic. Thank you. And I would also say that people have been commenting about ATAPS, which is funding for people on low incomes, available in most of Australia, and it has up to 18 sessions a year. And the other thing is the Mental Health Nurse Incentive Program. So lots of mental health nurses have training and experience in dealing with complex trauma, and some GPs are lucky enough to have one, or psychiatrists associated with them in their practice. And hopefully the budget will result in that program being reignited. Now, I'm just aware that we haven't heard from Richard since the beginning, and we've only got really a couple of minutes left. But I guess, Richard, I'd just like you to give you the opportunity to just say anything that you feel we've missed or that you've been burning to say.
Well, the first thing is I'm sorry I went so quickly and some people didn't see me. Most of what I said is on the slide. The second thing is that the people who presented tonight come from very different backgrounds, but in fact there are more similarities than there are differences, and what's important is in valuing the person who has the trauma, and that's you're more than halfway there once you've got to that point. And the final thing is, although it might be possible to do some things in 10 sessions, we really need to acknowledge that for most patients who've had severe and prolonged early abuse, that's not going to be effective. We've got two funding models that I see in Australia. We've got, in general, one that acknowledges that people have schizophrenia and they need hospitals and pills and supported accommodation, and another group of people who the government think will get better in 10 sessions. And the complex trauma people don't fit anywhere. We really need to lobby as a group for major funding injections for that group of people.
Thanks, Richard. And I'm very cheekily going to say I also think a lot of the people with schizophrenia have got complex trauma as well.
Absolutely.
But that's probably for another discussion.
Absolutely.
Thank you all so much. Kathy, you talked to us about the complexity and the need for having a trauma-informed approach. Richard, I really enjoyed the stuff about joining and representation and amplification, and clearly many people hadn't heard of that before. Philip Batesons' proposition about the mind of many parts. Johanna also spoke about Dan Siegel's work, and I think some of the neuroscience is talking about integration from a neuroscience perspective as well. So it's just really helpful to be able to think about these things in a holistic way. And some of your practical things were really appreciated by the audience, like the stress-free chair. And Johanna, lots of people said they wish that you were the referring GP for their clients. And, talking again about complexity, about awareness and coherence of your own self, I just think that's so important, something that many of us in our different disciplines are not trained very well in. So at another time, maybe we need another one of these, but it would be really interesting to know how practitioners can come to that awareness in themselves. The way that I know is having your own therapy, and that's not available to everybody, but maybe it's important. And then I think reflecting that the divided self is often manifest in communication with others, so divided communication, but also can often, our system is so divided. So I guess it's a really good opportunity to end our discussion tonight just on how good it is to see people collaborating, and Richard's comment that in fact we're all from different disciplines, but the similarities are standing out more than the differences. And I think that leaves us in a position of hope that we can begin to understand trauma in a much more coherent way, and hopefully for people in all sorts of places to be starting to have a trauma-informed approach. So thank you all so much, and if the audience would be happy to complete the survey, that'd be great on your way out. Thank you so much. Good night.
Thank you very much.
Thank you.
Our audience, if you're still there, you're going to get a link to the resources within the next couple of days.